Hello, and welcome to Let's Talk SADS Live, our Canadian webcast by the Canadian SADS Foundation, Sudden Arrhythmia Death Syndromes Foundation, SADS. And I am your host, Dr. Shu Sanatani, and delighted to be coming to you for what I'm told is episode 30, which is an exciting milestone to reach. And coming to you from Vancouver. And I know I'm reaching some of you in all kinds of different places around the world. And while I try and share my slides here, yes, got an exciting talk for you today with the autonomic nervous system and its effect on heart rhythm. So, um, looking forward to that. As many of you know, sudden arrhythmia death conditions are often diagnosed in young, otherwise healthy people. They can affect them tragically and suddenly with a sudden collapse or cardiac arrest or even death in young, seemingly healthy people. So, our job here at the Canadian SADS Foundation is to make sure that we educate the public and that we advocate and support families who have uh, experienced these losses and who are diagnosed with these conditions. Now, fortunately, most of these conditions are easily managed and treatable by special uh, clinics. So, we're going to talk about that. Um, we are very grateful to be supported by these organizations. And those of you who tune in regularly have seen these names: Lexio Therapeutics, Solid Biosciences, Tenaya Therapeutics, and Thrive Therapeutics. And all of these companies had a vision many years ago to improve our treatment of SADS conditions, to become more specific and personalized in our care of these very um, complicated ion channels that we we see, or heart muscle proteins. And so companies have developed new treatments. We're very grateful for their support, allowing us to do things like this webcast and advocacy and support families. So thank you very much. And that's my cue to ask you, our audience, to feel free to donate to the SADS Foundation. We are very dependent on your generosity. And go to the website, www.sads.ca, and feel free to make a donation. Now, as I mentioned, we've been doing these webcasts for 2.5 years almost now, and have placed them on the internet, on YouTube and on Facebook. Some of you joined in live, and now we have a couple of additional um, media for you to join in on the Spotify platform or on Amazon Music. And these platforms allow you then to listen at your convenience. Um, as you know, apart from a couple of slides that I show, this is mostly a conversation, so you can definitely get the full benefit from the audio on your drive to work. No distracted driving, please, and catch our broadcasts. And we are hopefully launching on Apple Music soon. So our new executive director, Guido McGuigan, I may have mispronounced that. He has been slowly taking over from Pam Husband, who served us for all these years, and he's bringing some of his youthful technology to us. So we're delighted to have Guido join us and to be on these new platforms. So as you know, I like to give us a little bit of a some Canadian content, and make it somewhat relevant to our topic or history. And so today we're talking about the autonomic nervous system, and we're going to really dive into that. And so just a news story from last summer from Brock University, which of course is a Canadian institution, and the team there were researching how our brain regulates blood pressure. And of course, so many of us have heard of blood pressure or hypertension or high blood pressure. It's a very common affliction that affects us as we get older. We rarely talk about it in the SADS realm because many of our patients, as we know, are young, otherwise healthy individuals. But this was a really interesting study where they examined how the brain, particularly with aging, the sympathetic nervous system, which we're going to talk about, actually contributes to blood pressure as you age. So nice to see Canadian research going on into such an important field. Looking ahead, we have Dr. Dominic Abrams joining us next month, and we're going to talk about arrhythmogenic right ventricular cardiomyopathy, ARVC, and we've talked a bit about that before, and Dr. Abrams will bring a vast amount of experience and research to our conversation next month. So today, I'm delighted to be chatting with Dr. Victoria Claydon, or Professor Victoria Claydon, who I've known a long time. Hopefully, when we talk about her bio a little, we're going to figure out exactly when we met. And so please join me in welcoming Dr. Claydon. Dr. Claydon, I'm gonna default to calling you Vic periodically. And it's so wonderful to have you here. I think it's been about 20 years that we've been talking together on the autonomic nervous system. Not that either of us can possibly be that old. So welcome.
Oh, thanks, Shu. Yeah, it's lovely to be here. It's got to be getting close to that, hey? 15, 20 years now? Yeah.
I believe so. So take us a little bit through your journey for our audience. Dr. Claydon is what I refer to as the smart type of doctor, not a medical doctor, but one who actually has done years of research to earn the Ph.D. doctor. So tell us a bit about how your journey began, and maybe even the slight accent.
Yeah, well, as you can tell from the accent, I didn't train in Canada. I was born and raised in the UK, and I did my B.Sc, so my science bachelor's in physiology in Leeds, in the north of England. And I stayed on there and did a Ph.D. and a postdoctoral fellowship with Professor Roger Hainsworth, who was really one of the world leaders in better understanding fainting spells or syncopal episodes, those loss of consciousness events when people fall to the ground having had a faint or a loss of consciousness, and nobody really understands why. And so I trained with him in the UK, and then I'd completed a second postdoctoral fellowship here in Vancouver at the ICORD Spinal Cord Injury Research Institute that's affiliated with UBC, with the University of British Columbia, working with Dr. Andrei Krasyakov, and that was looking at the autonomic complications, this time in individuals with injuries to the autonomic nervous system, so focusing on people with spinal cord injury. And then in 2008, I started here at Simon Fraser University, where I've got my own research lab now. And we really focus on cardiovascular physiology and pathophysiology, particularly looking at the regulation of blood flow, blood pressure, the heartbeat, blood flow to the brain, the autonomic nervous system, and these fainting spells or syncopal episodes.
So quite a journey, and definitely lots of research experience. And Dr. Claydon and I have had the privilege of working together, supervising some master's students and PhD students. So really, preparing the next generation for these hard questions. So we've dropped the term now a few times. It was in our title, autonomic nervous system. I think most of our audience has heard of the nervous system, or even the central nervous system. Tell us what you mean when you say the autonomic nervous system.
Yeah, well, I guess the clue is in the name. It refers to autonomy. So thinking about an independent nervous system, or maybe a self-governing nervous system is a better phrase. It's a part of the nervous system that maintains many of the body's needs, typically without conscious effort. And it's everywhere. It regulates every organ and system in the body. And people often think of it as being a nervous system that acts independent of will. And that's sort of true because, for example, it regulates your breathing without conscious effort while you're sleeping. But it's also not true because you can do breath holds and you can override it. So it's autonomous, but it can also be regulated. And so it's that nervous system that controls all of the things that for most of us, most of the time, we don't really think about.
And a lot of it, of course, resides in the spinal, in the spinal cord or adjacent to the spinal cord, as you've mentioned with your years with the I-Cord Institute. And I guess the brain must be connected.
Yeah, it's all
well.
It's all interregulated. So the brain's regulating the nerves, and some of them run through the spinal cord, so they're quite vulnerable to injuries, spinal cord injuries. Some of them don't pass through the spinal cord, and so they're less susceptible to, at least to spinal cord injuries. But in general, the autonomic nervous system is profoundly regulated and interrelated. So the regulation of the heart doesn't occur in isolation. It's also being regulated with the blood vessels and with the lungs and with all other components of the body. So it's a very integrated system.
Yeah, I mean, to me, as a sort of a lifelong student, I continue to learn about this, and it's an incredible system that one can do. As you say, one can sleep and you keep breathing, but you can also, you can run after your child that's heading towards traffic or something, and you can suddenly run very quickly, and your heart rate responds and your breathing responds. So it's an incredibly fine-tuned machine. Now, I always like a little bit of history. How did people, if you know this, how did people sort of figure out that there was this whole other system that wasn't under your conscious, or mostly is not under your conscious control?
Yeah, I don't know that we really have good evidence of when it was really first discovered. The word autonomic nervous system was first coined by John Langley in the late 1800s. So we've certainly had this term and recognized this part of the nervous system for some time. But the idea that there was a nervous system that regulated bodily functions was known back in the 2nd century. Galen proposed that there was concerted action. That was one of the phrases used, or sympathy of the organs. And that perhaps comes into play when we think about the subdivisions of the nervous system, of the autonomic nervous system. There's an ancient Egyptian text. It's known as the Edwin Smith Papyrus, and it's a text that details traumatic injuries. And it mentions in that there are autonomic nervous problems when the nerves in the spinal cord that regulate autonomic responses are damaged. So we've certainly known about it for a long time. And yet despite that, we're still learning so much about it now. So it's kind of intriguing to me.
Yeah, no, incredible what those early minds and saw and hypothesized, and we here are still unraveling. Now, when I was in medical school a long time ago, the autonomic nervous system was, we didn't learn a lot about it, and it was relatively simplified into two branches. You've mentioned, I mentioned in my opening the sympathetic nervous system, and so just give us the broad strokes, the two components that we think of.
Yeah, so we typically think about there being a sympathetic branch of the nervous system, and this is the one that's often referred to as the fight and flight version of the nervous system. So it gears you up for action, raises your heart rate, raises your blood pressure, raises your breathing, and so on. And then we have a parasympathetic component of the autonomic nervous system. This is the often called the rest and digest component of the nervous system. So it prepares the body for relaxation. It quiets the heart rate. It slows the breathing. It's mostly active when you're sitting quietly or sleeping. And so we tend to think of these as the kind of two branches. These are controlled by the brain, and they report sensory information back to the brain. So it's a two-way street, allowing for coordination of autonomic nervous system control and sort of connection between different bodily functions, so it can be fine-tuned all the time for the body's needs. And actually, there's a third kind of neglected part of the autonomic nervous system that I suspect we're going to neglect today as well, because I think we're more focused on the heart today. But there's an enteric nervous system as well that's part of this system that mainly regulates gastrointestinal function, so regulating the guts and the digestive system. But I'm guessing today we're going to focus on the heart, so those two, the sympathetic and the parasympathetic parts.
Yes, no, absolutely. We're going to keep it to heart focused, but no, wonderful those sort of catch phrases, fight or flight, and often we think of adrenaline, that example of running after your kid who's walking towards traffic, so it gives you this burst of adrenaline, or that rest and digest where you feel sort of sleepy after a big meal. And most of us, I think, when the autonomic nervous system is functioning well, most of us don't even think about it. It's just sort of running in the background, much like a reliable car, or when your computer is working, and you don't necessarily think about it. So the most common misstep of the autonomic nervous system is that what we've alluded to is fainting or syncope. So let's jump into there, because for so many of our families, syncope or fainting is one of the ways that they presented or came to recognition, or they have family members. So let's dive into fainting a bit more. So at the high level, what is fainting?
Yeah, I mean, the simplest definition of fainting is it's a transient loss of consciousness. So you lose consciousness, you typically will fall to the ground, but it's usually short-lived. And it's often a problem with regulation from the autonomic nervous system, because part of what the autonomic nervous system does is regulates the heartbeat and the blood pressure. And so if your heartbeat isn't matched to what your body needs in terms of controlling your heart rate or your heart rhythm, or how powerfully the heart's contracting or how hard it's beating, then not enough blood gets pumped around the body. And if not enough blood is pumped around the body, then not enough blood goes to the brain. And the brain, if it's not getting enough blood, it's not getting enough oxygen, it doesn't function properly, and that will cause a loss of consciousness. So it can be a problem with the regulation of the heartbeat, but it can also be a problem with regulation of the blood pressure. So if your blood pressure gets too low, then you don't push enough blood up to the brain, not enough blood is delivered to the brain, and again, it can cause a faint. So if the autonomic nerves aren't working properly to control either the heartbeat or the blood pressure, then you can experience a faint or a syncope, as it's termed.
And of course, I mean, most of the general population who have syncope, it's quite common. I think, we sort of think 1 in 3 people or maybe even more have fainting. So what are some of the differences between these? Your blood pressure is low because you've been standing in the hot sun for a long time, or you've been lying in bed and you get up and go to the bathroom in the middle of the night. Those kind of faints versus the ones that we're more concerned about. So, the ones that really are the hallmarks of some of the SADS conditions.
Do you mean differences in terms of what the body's doing, or differences in how it presents?
Well, let's start. Well, why don't we together talk about some of the different presentations, and then we'll pick on you to help us understand why some faints are common faints, benign faints. Mike Ackerman, our friend and with the SADS US, he calls them vanilla faints. So how are we differentiating? Just what's the difference in the story that the people with the common faints are telling?
Yeah, I mean, I think these common faints, anyone can have them. The autonomic nervous system is fantastic at its job, but ultimately it's got a finite response. And so if you have a strong enough stimulus to, for example, drop your blood pressure, eventually it overwhelms your body's ability to compensate for that. And so anybody can experience a faint, and these sort of common faints, or the I suppose the less concerning types of faints, tend to happen in people where that response has become overwhelmed. And so their blood pressure falls very low, their heartbeat can beat very slowly. They often feel quite unwell at the time. They feel quite nauseated, quite dizzy, their vision will go blurry, their hearing will go muffled, and that all relates to the lack of blood flow to the brain, that it's not being perfused properly, and so it starts to produce feelings of dizziness and lightheadedness and visual disturbances. And in this case, because it's a sort of failure of the normal compensation, once the person has the faint, usually they'll fall to the ground, they recover very quickly. They don't need resuscitation, they don't need any additional support, their blood pressure is restored, and they come around often actually feeling surprisingly good after the episode has happened. It doesn't typically leave them with a very long period of feeling unwell afterwards. Whereas the ones that we're more concerned about are probably more related to arrhythmia, so to irregular heartbeats. And those are the ones where the warning might be a little bit less typical. So less of that sort of dizzy, nauseated feeling beforehand. Sweating is very common with the sort of typical, the unconcerning faints, and a little bit less common perhaps with the arrhythmic faints. They tend to come with a bit less warning, and afterwards the recovery isn't always as speedy, and sometimes people need intervention to help them recover.
And I'm just going to sort of take us back for a moment and just talk briefly about numbers. So I mentioned, if we think 1 in 3 people faints, that's extremely common. That means, probably lots of people in our audience, have fainted or know people that faint. And so, and one can have both types of faint. So one can have a SADS condition, one can have an arrhythmia condition that causes a dangerous type of faint or is a warning sign, and you can have the common type of fainting. And the lead in isn't always that easy to separate, because the common factor is that your brain is not getting enough blood. And so a brain that's not getting enough blood can behave. But then, of course, in the common faint, the safe type of faint, you usually wake up. You may be a bit, briefly confused, but you wake up. Whereas in an arrhythmic faint, you may, as Dr. Claydon says, you may need someone to give you CPR or give you even a shock with a defibrillator, so that the duration of the episode, the amount of warning you have. But these are quite nuanced things, and thus people who have fainting, often are seen in hospitals and by doctors just to review their histories. Mm-hmm. Now, the SADS conditions themselves, we know there is an autonomic component to the arrhythmias. So let's go way back to almost 50 years ago, I think now, or about that, when people started looking at long QT syndrome, which is, of course, the most common ion channel form of SADS condition. And tell us a bit about your understanding of how the autonomic nervous system is a factor in long QT syndrome.
Well, I suppose the first question is, which type of long QT syndrome? Because there's different types, and they present differently, and they might have different autonomic triggers for the different subtypes. So, for example, the long QT syndrome type 1, that tends to have a trigger that's related to that fight or flight kind of response, and it's often associated with swimming. The long QT syndrome type 2 tends to be more likely to have a trigger that's a sudden arousal from a quiet autonomic nervous system, like waking up from sleep with a sudden startle response. So they both have common parallels in that they both have features of when the arrhythmia occur that might be related to autonomic triggers, but they don't share the same features, and that's related to the underlying genetics of the conditions.
Yeah, and thanks. I put you on the spot there asking you about long QT, and exactly as you point out, the triggers often are very specific, and the least common form of long QT, type 3, the trigger is often not that evident. It's often events occurring at rest or sleep, and so the autonomic nervous system is definitely a factor. And Peter Schwartz of the Schwartz score for diagnosing long QT, he of course was very in tune with this autonomic nervous system, and both he and Michael Ackerman are big proponents of a procedure called cardiac denervation or ganglionectomy, where we actually change the innervation of the heart by removing a part of the autonomic nervous system. So cardiac denervation, and some of our viewers may have even had this procedure. And so we try and manipulate the autonomic nervous system in some of these challenging cases. So tell us a little bit about, you and I have had lots of conversations, and we're trying to understand this concept of, for example, the swimming. So people continue, people sort of recognize that fainting during swimming is very unusual and should prompt an evaluation. What is it that's going on with swimming that is of such interest and shed some light into the autonomic nervous system?
Yeah, well, I think the short story is we're not completely sure, but we do have some ideas. And I think the first point to make is that, typically we think about the autonomic nervous system as kind of like a seesaw or a yin and yang, right? And you have the sympathetic that speeds everything up, the fight and flight, and you have the parasympathetic that slows everything down. And you have generally activation of one and the other one is quiet. And then when it's time to switch, you turn the other one on and you quiet. But I think that's probably a little bit overly simplistic. And we have a lot of good evidence nowadays that actually you can get co-activation of both sides of the autonomic nervous system at once. And there are times when that might be beneficial to cardiac function. There's some hints around that during very high level exercise, particularly in well-trained people. But there are times when it might be sort of a confusing signal to the heart, because you're telling it to speed up and beat powerfully and to slow down and beat less powerfully at the same time. And it doesn't really know what to do. And so it can produce arrhythmias. And in swimming, you have lots of signals that activate that fight and flight. So when you jump into cold water, that will activate a flight and fight response. When you're exercising, that will activate your fight and flight response. If people are swimming and they're in a competition, that will also, produce a bit of nervousness or anxiety, and that will activate it as well. So you have lots of things turning on the sympathetic side, the speed up and beat powerfully side. But at the same time, when you do breath holds, when your face is under the water, and when cold water hits the face, it produces a diving response. It produces a parasympathetic response, that rest and digest, that slow everything down and quiet the heartbeat response. And so in swimming, you can get both of those at the same time. And we think that might be one of the reasons why it can be triggering for arrhythmias in susceptible people. It doesn't mean that swimming's always a problem for everyone, but maybe there are certain conditions where it can be triggering, and things like when the water's very cold might be worse, for example, than swimming in a public swimming bath where it's not so cold.
Yeah, and thank you for reminding us. We want to not, have everybody that's ever fainted, again, 1 in 3, very common. We don't want to have them now worried, thinking that they have an undiagnosed SADS condition.
Yeah, absolutely.
The history is important, your family history, those kind of things. Swimming has been a great learning point for me and others doing work in this space, because as you say, we used to think of things as a seesaw. You had adrenaline, or you were slowing down. But I think really those situations, they show that both systems are on alert and ready to be activated. And so swimming, they come into, and I don't know who coined the term, but you taught me the term of autonomic conflict, where both the systems are competing. I'm thinking of those TV shows where one used to see one voice on one shoulder and another voice on another shoulder, talking the person into buy the dress and don't buy the dress, or whatever the dilemma is. It's almost like the heart is then caught between two different influences.
Yeah, absolutely. And I think swimming's one of those possible provoking factors for that conflict. And I think not all conflict is equal, and that also makes it challenging. Like we were saying, not everyone who experiences these co-activation, this autonomic conflict, is going to have a problem with it. But the more that we look into it, the more that we see examples of conflict in daily life. And I think it's probably more common than we ever previously recognized.
Well, I think, especially for those of us who have been spending, some time in these sudden arrhythmia death conditions and sudden cardiac arrest, we sometimes will make a diagnosis, for example, long QT syndrome or catecholaminergic polymorphic VT. So we might find the underlying condition, and we might find the specific trigger on that day, a swimming competition, a stressful time in the life. But that coming together, that why did the lightning strike on that day? Most of these young people have done hundreds of swimming competitions, or dozens of them. They've run track and field hundreds of times. So it's that missing factor that keeps us doing research and asking these questions. Now, in your work in autonomic conflict, or in the swimming population, and I know you've done some work in artistic swimming, are you seeing some abnormal rhythms? Are you seeing some signal there?
Yeah, we are, and I think it's a question really about what is abnormal for that activity. How much of a alteration in the heart rhythm is kind of normal for what that person is doing, and how much of it is concerning. But we certainly do, and we see them in the times when you might expect there to be autonomic conflict. So artistic swimming, for example, has really long periods of breath holding, and it has it in people where they've trained their dive response to be very effective, because that helps them to be able to hold their breath for longer. And so in these individuals, there does seem to be quite a strong break coming on while they're doing their exercise, because they've, as a consequence of their years of training, that mechanism has been fine-tuned. And so we do see irregular heartbeats, and I think we're still looking a little bit at these data to figure out whether that's something concerning or whether that's a feature of the sport. But certainly if autonomic conflict is experienced, we are seeing irregular heartbeats with it.
And and likely there are events of autonomic conflict or autonomic misfires that we never actually that don't lead to anything, a few extra beats here and there, or I felt a bit odd. But to actually progress to a more dangerous rhythm is thankfully very rare.
Mm-hmm.
And so let's talk a little bit about a different aspect of the autonomic nervous system, because we even though we have a limited understanding of it, modulating it is one of our main forms of treatment for SADS conditions and medical treatment of abnormal rhythms, arrhythmias. For example, one of our main treatments is beta blockers. So, as an autonomic specialist, just give us a quick overview. What are why are we using beta blockers for all these conditions?
Well, it's the same rationale as the surgeries to remove the autonomic fight and flight nerves to the heart. If we quiet one side by quieting down the sympathetic nerves with the beta blockers, then maybe we can sort of make the heart a little bit less reactive to stresses, and so we can prevent some of these arrhythmias from being triggered. And I think they're obviously very effective, and so are the nerve surgeries that are being done as well. The challenge is that they're probably more appropriate for certain types of heart conditions than others. So the ones that are very sensitive to catecholamines, to the fight and flight hormones, to adrenaline, to noradrenaline, conditions like CPVT that I'm sure you've talked about previously on these episodes, those conditions would probably really benefit from turning down the sympathetic nervous system a little bit. But conditions like Brugada syndrome, for example, which tends to present when the heart's in the quiescent mode, when the parasympathetic nervous system is dominant, tends to present with irregular heartbeats in sleep and during rest, is probably not going to respond to beta blockade, and actually it might be detrimental.
Right. Yeah, no, and thank you for bringing up Brugada syndrome, because again, our advice there is often to avoid, heavy meals and late meals and, a lot of alcohol consumption, particularly, around sleep. So the other side of the autonomic nervous system, and of course, as treating physicians, we are always reminding people to keep taking your beta blockers, because your body gets used to the medication and sort of up regulates and becomes more sensitive. So taking beta blockers irregularly or erratically can actually be quite dangerous, and probably can set you up for autonomic conflict. So
well, and I think because they are often very effective, you take them day after day after day, and you're not having any problems. So then you question whether you really need them. But the reason perhaps that you're not having any problems is because they're working really well. So
it's one of those very, very tricky things where people ask you, how do I know my treatment is working? I feel, I don't feel any different, or I have some side effects perhaps. And that's exactly it. The treatment is working because you're doing well and you're not having events. In our last few minutes here, I think the autonomic nervous system got a bit more attention. We, during the pandemic, some people started talking about autonomic nervous system function being potentially affected by COVID, and it just feels like now people, it is reaching a bit more into the public awareness. Take us, if you will, what do you see the future, of the, are we going to get better at researching it? Are there some things you're excited about that are going to develop, or that are in the works, or is it still going to be, as it was with the Egyptians, who say, well, it's just part of how the body works and we don't really understand it? What are some things that you're involved in or hopeful about?
Yeah, I mean, I think we have to pay attention to it because, going right back to where we started, it controls every organ and system in the body. So we need to pay attention to it, and we need to better understand it and better manage these kinds of conditions. I think there's a lot of renewed interest in nerve stimulators. So stimulating either the fight and flight side with spinal stimulators, or stimulating the vagus nerve with stimulators actually that often go on the ear and catch a branch of the vagus nerve and stimulate it there. So I think we're going to see a lot more research in those areas of how we could moderate the autonomic nervous system perhaps without having to do surgeries necessarily, do it non-invasively. And I think just that sense of awareness, you're right about the COVID pandemic and raising awareness. And there are certain types of autonomic nervous problems that seem to be associated with a post-viral onset, a post-traumatic onset, sometimes post-concussion type onset, probably speaking to that relationship between the brain and the autonomic nervous system. And we didn't talk about it today, but the autonomic nervous system is also involved in your immune responses. And so I think there's going to be a lot more need and a lot more advances made in investigating those kinds of interactions and optimizing function for people where they've had, for example, a COVID infection and are now struggling with autonomic concerns.
And I'll take us in a slightly different direction. Also, I think the world has changed. Certainly, our world has changed a lot. And I've been reading about these phones that all of us have in our hands all the time, or within reach, and just the general busyness and constant stimulation that our brains are now getting. Where we're constantly, your phone buzzes and you immediately pick it up and you see the latest headline or your dinner reservation. And this sort of constant, I'll call it an assault on your senses, is definitely changing, I think, how our autonomic nervous system is functioning in the background. And I don't think it's a coincidence that, there are more things like stress and high blood pressure and some health ailments because we're stimulating the body and the brain so much more. So wonderful to think that that people are going to keep researching this and furthering our understanding. So Vic, it's always a pleasure to talk to you. I'll tell our audience that when I have a challenging question about fainting or why the body does something, Vic often will get a rather vague email asking her to explain these incredibly complicating concepts in one or two lines that I can digest. But I really appreciate you joining us today and the research you're doing, particularly this autonomic conflict. I think there's really some important insights there, and wish you all the best in educating us as this research advances.
Oh, thanks, Shu. And yeah, it's a pleasure to be here, and I've really enjoyed the conversation and our interactions over the years. It's been lovely.
Well, thank you. So we will wrap up our show today. As I mentioned, we're going to have Dominic Abrams here with us next month, and looking forward to seeing you all again. I think it's a long weekend for many of us here, and it feels a bit like spring. So we have enjoyed having you. Feel free to go to our website and check out what's there. Perhaps make a donation. You can still make a donation on the website, even without. I had a QR code earlier, and thanks again for joining us. We have learned a lot again today, as we always do.